everyone. Thank you for joining today's public webinar providing an overview of the Quality Payment Program policies in the calendar year 2024 Physician Fee Schedule Final Rule. During this session, CMS will provide an overview of the finalized policies for the 2024 performance year of the Quality Payment Program and offer resources for helping understand the final rule. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions. You can either submit written questions via the Q&A box, or you can raise your hand to ask the question live via webinar audio. CMS subject matter experts will address as many questions as time allows. As a quick reminder, a recording of this webinar and accompanying slides will be shared online on the Quality Payment Program webinar library within 2 weeks. Now I will turn it over to Sophia Sukumar at CMS to begin. Sophia?
Great, thanks, Olivia. Good afternoon, everyone, and thank you for attending today's webinar. Move to the next slide, please. One more slide, please. Okay, so with regards to today's webinar, we are going to cover several topic areas, which include updates to our MIPS Value Pathway policies, our policies within the traditional MIPS space, and also our advanced APMs and the policies associated with that. Public reporting and the Medicare Shared Savings Program will also be covered. And after that, we will have a Q&A session, and there will be some resources listed to help you read through our education outreach materials that are available on our website. Next slide, please. With regards to upcoming deadlines for the 2023 year, just a reminder, the MVP registration period for the 2023 performance period closes on November 30th. And our virtual group election period for 2024 closes December 31st. The last day to submit a PI hardship exemption is January 2nd and or a MIPS EUC application for the 2023 year. And another flag is that the January 2nd date also reflects when data submission opens for the 2023 performance period. Next slide, please. Okay, and just a reminder here with regards to our targeted review timeline, beginning with the 2024 performance period, the target review submission period will open upon release of MIPS final scores and remain open for a 30-day period after MIPS payment adjustments are released. And so this will maintain an approximate 60-day review period for requesting a target review. Again, that 60-day period is broken up in 2 ways: 30 days before payment adjustments are released and 30 days after payment adjustments are released. And this updated timeline is really there to ensure that we can have a complete all our reviews of our target reviews and come up with resolutions with regards to those, and then have a finalized list of qualified APM participants or QPs by the October 1st date, so that we could accurately reflect payments based off performance within QPP as it's implemented as of January 1st of the payment year. Next slide, please. With regards to our rule resources, we do have file resources available through our QPP website. Highly recommend you go take a look at those. That includes a fact sheet and a comparison table, as well as some FAQ documents that may help you navigate through our final rule materials. Next slide. In regards to our future direction within the Quality Payment Program, as we've outlined within the final rule, we are very much aware of the challenges that many have faced across the country over the past 3 years during the public health emergency. And we do remain committed to promoting more meaningful participation for clinicians in order to ensure policies continue to drive us more towards value and improved health outcomes for patients. So with that in mind, we continue to further goals in MIPS that align with that. And within the 2024 final rule, we focused in on continuing to implement new MVPs and also making modifications to some of our existing MVPs. And then we also made some updates to our inventories with relation to our quality measures and improvement activities as well. Next slide, please. Some key highlights just to flag here related to MIPS Value Pathways is that we, as I mentioned before, have finalized newly available MVPs, the 5 new MVPs that we previously proposed, and we have finalized revisions to previously established MVPs that will be available with the updates for reporting beginning with the 2024 performance period. So in totality, that brings us up to an inventory of 16 available MIPS Value Pathways that would be available beginning with the 2024 performance period. Next slide, please. And within looking at the realm of what we consider traditional MIPS to be, we did limit the changes within policies to really kind of continue to maintain some level of consistency as clinicians and stakeholders continue to familiarize themselves with MIPS Value Pathways and that new track. Some notable policy changes that we've included using a performance threshold and maintaining the performance threshold at 75 points rather than increasing it as we previously proposed. We also finalized maintaining the data completeness threshold at 75% through the 2026 performance year, continuing to make the quality the QP determinations at the APM entity level for the 2024 performance year, and maintaining the 75% threshold for cert used by advanced APMs for the 2024 performance year. Next slide, please. With regards to our MIPS quality measure and improvement activity inventory, we did finalize changes to the quality measure inventory that resulted in a totality of 198 measures available for 2024, which includes the removal of additional 11 measures and addition of 11 MIPS quality measures. We also made substantive changes to 59 of our existing measures. Within the realm of the cost performance period, we added 5 new cost measures, and each of those have a 20 episode case minimum. We also finalized the removal of the acute inpatient medical condition cost measure, which is the simple pneumonia with hospitalization beginning with 2024. And within the improvement activities performance category, we did finalize adding 5 new improvement activities and modifying 1 existing IA while removing 3 of our existing improvement activities. Next slide, please. For the promoting interoperability performance period, we did finalize the increase of the performance period for promoting interoperability from the 90-day period that it once was to 180 consecutive days within the calendar year. And now looking at our shared savings program portion of the presentation, we did finalize to establish the Medicare CQM measure collection type, which would be available for ACOs participating in the shared savings program as a new collection type for those ACOs that participate in the APP. We also, beginning on or after January 1st, 2025, and unless otherwise excluded, require an ACO participant, provider, supplier, or professional that is a MIPS eligible clinician, QP, or partial QP to report MIPS promoting interoperability, the category measures and requirements to MIPS to earn a performance category score for the MIPS promoting interoperability performance category at either the individual, group, virtual group, or APM entity level. Next slide, please. And with that, I will then turn it over to Jeanette Ellis to provide the MVP final rule policy overview. Thank you.
Thank you, Sophia. Go ahead and go to the next slide, please. Okay, in the 2024 QPP final rule, we finalized 5 new MVPs and revised all previously established MVPs. These MVPs will be available beginning with the 2024 performance year and are cited here. Of note, the value in primary care MVP reflects consolidation of the previously existing MVPs, optimizing chronic disease management and promoting wellness. Through the MVP development work, CMS will gradually implement MVPs for more specialties and subspecialties that participate in the program. We encourage you to visit the Explore MVPs webpage for more information. Next slide. Additions to our 2024 MVP final rule include broadening the opportunities for the public to provide feedback on viable MVP candidates. Draft versions of MVP candidates will be posted on the QPP website to solicit feedback for a 45-day period, which was previously 30 days. Through this development process, CMS will review all feedback and determine if any recommended changes should be incorporated into a candidate MVP before it is proposed in rulemaking. If it is determined changes should be made, CMS will not notify the group or organizations that submitted the original MVP candidate in advance of rulemaking. We encourage you to review the detailed instructions for MVP candidate development and formally submit MVP candidates for CMS consideration via the MVP Candidate Development and Submission webpage. And now I will hand it back over to my colleague, Sophia Sugamar, to discuss the MIPS final rule policies.
Great, thanks, Jeanette. Can we move to the next slide, please? Okay, to provide a basic overview of our 4 performance categories in MIPS, as a reminder, we have the quality performance category that's weighted at 30%, cost that's at 30%, improvement activities, which is at 15%, and promoting interoperability, which equates to 25%. And so in totality, that gives us the 100%. And the points of each of these performance categories are added together to give you your MIPS final score. And that MIPS final score would then result in either clinician receiving a positive, negative, or neutral payment adjustment. If you achieve enough points that meets our performance threshold at 75, then you would achieve a neutral. Anything above that, a positive. Anything below that would be a negative. Next slide, please. So just to provide a comparison here of our performance category weights, you can tell for 2024 within the MVP space and traditional MIPS for individuals, group, virtual groups, and APM entities, there are no changes. And similarly for the APP, the APM performance pathway for individuals, groups, and APM entities, there are no changes. So the various performance category weights are with the performance categories are cross-referenced here. And just a little side note, the APP has different scoring weights when compared to the APM entities that participate in traditional MIPS. So when an APM entity reports traditional MIPS, CMS will reweight the quality performance category to 55% according to the traditional MIPS performance category reweighting rules, as opposed to the 50% that's under the APP. Next slide, please. With regards to our third-party intermediaries, we did finalize our policies related to the health IT vendors, which would be that because we've had past histories of inaccurate and unusable data submitted to us, we did propose and are finalizing to essentially consolidate the availability of the health IT vendors within our third-party intermediaries choices, in that they would have to participate in MIPS as either a qualified registry or as a QCDR in order to submit data to us. And this begins with the 2025 performance period. Next slide. And with that, I'll turn it over to my colleague, Lisa Marie Gomez, for the quality performance category.
Thanks so much, Sophia. Next slide, please. So in the 2024 PFS final rule, we finalized an inventory of 198 MIPS quality measures for the performance for this upcoming performance year. So the inventory includes an addition of 11 MIPS quality measures, which includes 1 composite measure and 6 high priority measures, of which 4 are patient-reported outcome measures. We also, in part of the inventory, we made substantive changes to 59 existing MIPS quality measures. We also removed 11 MIPS quality measures, and we partially removed 3 MIPS quality measures. And what we mean by partial removal is that the measures were removed from traditional MIPS, but were retained for MIPS use only. I just want to note that the QCDR measures are not included in the above measure inventory. They're separate from this 198 MIPS quality measure inventory. Next slide, please. And I'm going to discuss the collection types that are available for Shared Savings Program ACOs that are reporting under the APP. So in the 2023 PFS final rule, the Shared Savings Program participants, or ACOs, had the collection types available to them, which included the CMS Web interface, the electronic clinical quality measures, also known as ECQMs, and the MIPS clinical quality measures, also known as MIPS CQMs. In the 2024 PFS final rule, we establish a new collection type that would be available only specific to ACOs reporting under the APP, specifically for the Shared Savings Program. So the collection types that are available, starting with 2024 performance year, include the CMS-Web interface, in which that will be the last year it will be available, ECQMs, that collection type, and the other collection types include the MIPS CQMs, and the new collection type is the Medicare CQMs. Next slide, please. Now I'm going to discuss data completeness. So in the 2023 PFS final rule, we increased the data completeness threshold to 75%. And in that rule, we established that the increased performance period for the 2024 and 2025 performance years. So our goal is to, in advance, let everyone know, when we're increasing the data completeness threshold, which is why in the 2023 PFS final rule, we established the data completeness for the 2024 and 2025 performance years. So in the 2024 PFS final rule, we finalized our policy to maintain the data completeness threshold of 75% for 2026. So for 2024, 2025, and 2026 performance years, the data completeness threshold is set at 75%. I want to note that with the establishment of the new collection type, the Medicare CQMs, the data completeness thresholds will apply for the new collection type. I also want to note that for the Shared Savings Program, for those that have the various collection types, I also want to note that the data completeness threshold also applies to those collection types, which is at 75%. Next slide, please. Now I'm going to discuss the ICD-10 coding changes. So in the 2024 PFS final rule, we modified our policy relative to how we assess ICD-10 coding changes. So we eliminated the automatic 10% threshold of coding changes that trigger measure suppression or measure truncation. We're also, the policy also allows the assessing to assess the impact of coding changes on a case-by-case basis. And it also allows the assessing of each collection type separately of a given measure in order to determine the appropriate action to take for a measure affected by an ICD-10 coding update. So again, this is just an update to our ICD-10 coding changes that allows us to better assess the coding changes that are done annually under ICD-10 codes. Next slide, please. I also want to note that our final quality policy relative to the quality performance category relates to the CAPS-RMIT survey. So in the PFS 2024 final rule, we are requiring groups, virtual groups, subgroups, and APM entities to contract with the CAPS-RMIT survey vendor to administer the Spanish survey translation to Spanish referring patients using the procedures detailed in the CAPS-RMIT quality assurance guidelines. So this is a new requirement for those that choose to elect to administer the CAPS-RMIT survey. We're also recommending groups, virtual groups, subgroups, and APM entities to administer the CAPS-RMIT survey and other available translations. That's not a requirement, it's just something we are encouraging and recommending. Next slide, please. Now I'm going to turn the presentation over to Ray DeSato to go over the MIPS final rule policies pertaining to the cost performance category.
Thank you, Lisa Marie, and hi, everyone. My name is Ray DeSato, and I'm the cost measure lead for the MIPS program. So for cost, we finalized as proposed. We finalized the addition of 5 new episode-based cost measures beginning in the 2024 performance period. They are psychoses and related conditions, depression, heart failure, low back pain, and emergency medicine. And all 5 were added with a 20 episode case minimum. We also finalized a proposal to remove the simple pneumonia and hospitalization cost measure beginning with the 2024 performance period. And for scoring, beginning with PY 2023, we are calculating cost improvement at the category level instead of the measure level as previously finalized. And then additionally, I'd just like to note that we documented in the rule an update in the attribution methodology for chronic condition episode-based cost measures. that we made as part of the annual maintenance for the 2023 performance period. And that is all I had for cost. I believe I'm passing it to Vidya.
Thanks, Ray. My name is Vidya Selpin, and I will be reviewing the traditional MIPS improvement activities or IA proposals that we have finalized for calendar year 2024. So we are finalizing the following changes to the improvement activities performance category. We are adding 5 new improvement activities. We are modifying 1 existing improvement activity, and we are removing 3 existing improvement activities. Of the 5 new improvement activities, we are including an MVP specific improvement activity, which allows clinicians reporting to an MVP to receive credit for adopting a formal model for quality improvement related to a minimum of 3 of the measures reported as part of their specific MVP. We are also adding 2 new activities that fall under the population management subcategory and 2 new IAs that fall in the behavioral health subcategory. We are finalizing to modify 1 activity, PSPA 16, which is use decision support and standardized treatment protocols to manage workflow in the team to meet patient needs. And we are removing 3 previously adopted improvement activities, implementation of co-location PCP and MH services, BMH 13, which is obtain or renew an approved waiver for provision of buprenorphine as medication assisted treatment for opioid use disorder, as this IA is now obsolete. And finally, we are removing PSPA 29, which is consulting appropriate use criteria using clinical decision support when ordering advanced diagnostic imaging, as this activity is also now obsolete as the CMS program has ended. There are now a total of 106 improvement activities in the MIPS inventory for 2024 performance period. All of these proposals can be reviewed in further detail in Appendix 2 in tables A, B, and C of the final rule. And in January, the updates to the IA inventory may be reviewed on the QPP website Measures and Activities Lookup Tool. This concludes the IA policies for 2024. I will now pass the presentation to Elizabeth Holland.
Thank you, Vidya. I'm Elizabeth Holland, and I'm going to talk about promoting interoperability. Next slide, please. Just as a reminder, this is the performance category that requires the use of certified electronic health record technology. So for 2024, we finalized that we will continue to reweight clinical social workers for the promoting interoperability performance category. The other clinician types that we have previously reweighted, we didn't propose to continue reweighting, so now they must all submit promoting interoperability data. Next slide, please. So as Sophia mentioned, we did increase the length of the performance period since the beginning of MIPS. It has been 90 consecutive days, and we believe that if you're using your certified chart technology all year, you should be able to report to us for a performance period of 180 days. And that's a minimum. You can do a longer reporting period, performance period, if that is what you select. And this 180 days does align with the reporting period that we established for the promoting interoperability program for eligible hospitals and critical access hospitals. Next slide, please. So we did modify 1 of the exclusions, and this is for our query of prescription drug monitoring program measure. Previously, we had said, oh, the exclusion would just be if you wrote fewer than 100 permissible prescriptions, and that really wasn't applicable because it would doesn't mean that you've written any Schedule 1, 2, 3, or 4 drug. So we did modify this exclusion to specifically call out that. So hopefully that would be helpful to MIPS eligible clinicians. Next slide, please. Also, we've had the SAFER guide measures. That's the safety assurance factors for electronic health record resilience, or SAFER guide measure. We only require have a measure for the high priority practices guides. And in the first 2 years that we had this measure, we had it be a yes or a no would successfully fulfill the measure. Starting in 2024, you will need to attest yes. If you attest no, you will earn a score of 0 for the promoting interoperability performance category. Next slide, please. So now I am turning it over to Zenobia Rasberg.
Thank you, Elizabeth, and good afternoon, folks. I will be talking through our final scoring finalized policies. This year, we included policies related to scoring subgroups, as you can see on the slide, and our performance threshold. So to begin with subgroup scoring, beginning in the 2023 performance year, subgroups will be eligible to receive their affiliated groups complex patient bonus. On the other hand of the spectrum, facility-based measurement, subgroups are not eligible for facility-based measurement, as that is only available in traditional MIPS. Next slide, please. So in reference to our performance threshold, we will be maintaining the performance threshold at 75, again, for the 2024 performance year. Next slide. And on this slide here, you can see the no change represented, in which 75 points will earn a neutral payment adjustment, and over that we'll get a positive payment adjustment. And again, as a note, there is no more additional performance threshold or additional or exceptional performance threshold. Next slide, please. And now I will be turning it over to Richard Jensen for our advanced APM policies.
Thank you, Zenobia. We, for advanced APMs, we're finalizing with modification one of our two major proposals aimed at encouraging broad clinician participation. As Sophia mentioned at the top of the presentation, we did propose to amend how QP determinations are calculated at the QP status, taking the individual clinician level rather than APM entity level. And we are not finalizing this proposal so that we will continue. In other words, we will continue to make QP determinations at the APM entity level. Our second proposal was we are finalizing changes to the certified EHR technology criterion for advanced APMs in alignment with related changes in MIPS and the Shared Savings Program. We are finalizing as proposed to amend the cert definition to give advanced APM flexibility to tailor their cert requirements to the participants' clinicians' practices. And I won't go through this entire slide, read out this entire slide, but as you can see, we're providing greater latitude and flexibility here than we have had in the past. In addition, we had proposed to do away with the 75% threshold and require that all participating eligible clinicians meet the cert requirement. We have modified that, and the 75% threshold will remain in place for 2024, and then it will no longer be in place. In other words, beginning in 2025, all eligible clinicians participating in the advanced APMs will have to comply with the cert criterion. I'll pass it now to Julie Johnson.
Thanks. Next slide, please. We have finalized updates to existing policies around the public reporting of utilization or procedure data and the publishing of telehealth indicators on individual clinician profile pages of the Medicare.gov website. In 2023, when we finalized the public reporting of utilization data for the individual clinician profile pages, we identified the volume of procedures performed using only Medicare fee-for-service data. For a more complete scope of clinician experience among the Medicare patient population and to address low volume counts, CMS will start publicly reporting Medicare Advantage encounter data in addition to Medicare fee-for-service data during the beginning of 2024. And these two data sources will be aggregated together when we start posting that. We also finalized publishing an indicator for clinicians providing telehealth services on the compare tool of Medicare.gov in 2023 and identified these clinicians using the codes POS2 and POS10, as well as the modifier 95. CMS has updated the existing policy to identify clinicians using the most recent codes at the time data is refreshed to reduce annual regulatory burden and to avoid inaccuracies due to coding updates occurring outside of the physician fee schedule rulemaking cycle. I will now turn it over to my colleague Sabrina Ahmed, who will go over updates for the Medicare Shared Savings Program.
Thanks, Julie. I'll be reviewing the Shared Savings Program quality policies. Next slide, please. As mentioned earlier in this presentation, for performance year 2024 and subsequent performance years, we finalized our proposal to establish Medicare CQMs as a new collection type for Shared Savings Program ACOs under the APP. A Medicare CQM is a CQM reported by an ACO on Medicare patients with claims encounters with ACO professionals with specialty designations used in the Shared Savings Program assignment methodology during the quality performance period, or who has designated an ACO professional participating in the ACO as responsible for coordinating their overall care instead of its all-payer, all-patient population. So ACOs will continue to have the option to report quality data using the CMS web interface measures ECQMs and/or MIPS CQM collection types in performance year 2024, in addition to the new option to report quality data using Medicare CQMs. And then in performance year 2025 and subsequent performance years, ACOs will have the option to report quality data using the ECQMs, MIPS CQMs, and/or the Medicare CQM collection type. We will provide each ACO with a list of beneficiaries eligible for Medicare CQMs each quarter throughout the performance year as part of the ACO's quarterly informational reports packages. This list will be cumulative and updated to reflect the most recent quarter's data. ACOs will still need to evaluate their patient population against each Medicare CQM specification prior to submitting their quality data, including confirming the beneficiaries meet the numerator and denominator criteria for the measure. The first quarter report packages are typically delivered to ACOs in May of the performance year via the ACO management system. The standards for data completeness, benchmarking, and scoring ACOs for the Medicare CQM collection type will continue to be aligned with MIPS policies. We also finalized that ACOs that report Medicare CQMs will be eligible for the health equity adjustment to their quality performance category score when we calculate their shared savings payments. Next slide, please. So in order to align the shared savings program cert requirement with MIPS, we finalized our proposal with modification to delay 1 year to sunset the shared savings program cert threshold requirements beginning performance year 2025, and to add a new requirement that for performance years beginning on or after January 1, 2025, unless otherwise excluded, an ACO participant, ACO provider or supplier, and ACO professional that is a MIPS eligible clinician, QP or partial QP, regardless of track, will be required to report the MIPS promoting interoperability performance category measures and requirements to MIPS and earn a performance category score for the MIPS promoting interoperability performance category at the individual group, virtual group, or the APM entity level. Additionally, we finalized with modification to delay by 1 year a proposal to add a new requirement for public reporting, requiring that the ACO must publicly report the number of ACO participants, ACO providers and suppliers, and ACO professionals that are MIPS eligible clinicians, QPs, or partial QPs that earn a performance category score for the MIPS promoting interoperability performance category. Next slide, please. This slide covers two major policies we finalized with regard to revising the quality performance standard under the Shared Savings Program for performance year 2024 and subsequent performance years. We will use historical submission level MIPS quality performance category scores to calculate the 40th percentile MIPS quality performance category score. Specifically, we will use a rolling 3 performance year average with a lag of 1 performance year. So this means that the 40th percentile MIPS quality performance category score used to determine the quality performance standard for performance year 2024 will be based on averaging the 40th percentile MIPS quality performance category scores from performance years 2020 through 2022. We will provide ACOs with the 40th percentile MIPS quality performance category score for an applicable performance year prior to the start of the performance year. So the 40th percentile MIPS quality performance category score for performance year 2024 will be released on the Shared Savings Program website in December 2023. The second policy is related to applying a Shared Savings Program scoring policy for excluded APP measures and APP measures that lack a benchmark. Given that Shared Savings Program does not determine which quality measures do not have a benchmark, and that ACOs do not have a choice of measures they can report under the APP, we do not want to adversely impact shared savings determinations for events outside the ACO's control, such as in the event a measure does not have a benchmark. So therefore, for performance year 2024 and subsequent performance years, we finalize that if an ACO reports all of the required measures under the APP, meets the data completeness requirement for each measure, and receives a MIPS quality performance category score, then we will use the higher of the ACO's health equity adjusted quality performance score or the 40th percentile MIPS quality performance category score to determine whether the ACO meets the quality performance standard required to share in savings at the maximum rate when the ACO meets either one of the following two criteria. The ACO's total available measure achievement points used to calculate the ACO's MIPS quality performance category score, it was reduced due to measure suppression, or at least one of the ECQMs, MIPS CQMs, Medicare CQMs used in calculation of the MIPS quality performance category score does not have a benchmark. So this is the end of the Shared Savings Program part of the presentation. Next, I would like to hand the presentation back to Julie Johnson. Thank you.
Hello again. I will now go over the 2024 Quality Payment Program resources we have available. Okay, there it is. CMS has published several resources on our online QPP resource library, which can be found at the link qpp.cms.gov/resource-library. First, CMS has an overview fact sheet and policy comparison table for users, which provides an overview of the Quality Payment Program policy updates included in the 2024 Medicare Physician Fee Schedule Final Rule, and a comparison table contrasting existing 2023 policies with updates for 2024. Users will be able to find a guide to the MVPs finalized for implementation beginning in the 2024 MIPS performance period. This includes the 5 new MVPs as well as modifications to all previously finalized MVPs. And finally, CMS has also included FAQs or frequently asked questions in a downloadable file called 2024 Quality Payment Program Final Rule Resources on the resource library. Last but not least, a link to the 2024 Medicare Physician Fee Schedule Final Rule is also posted. Next slide, please. Now I will turn it over to Ketchen to go over the Q&A portion of the webinar.
Great, thank you, Julie, and thank you for all of our speakers. So as Julie mentioned, we're now going to start the Q&A portion of the webinar. As a quick reminder, you can ask questions using the Q&A box, which we've seen quite a few people doing. And you can also raise your hand if you'd like to ask a question live via webinar audio. Before we begin, we did just want to remind folks that the Q&A today will focus on questions related to the final rule. So any other questions you can submit to the help desk. And to get us started, can we go to slide 30? We just had a request for someone to see the bottom of that slide really quickly. Perfect. We can go back to the Q&A slide, 48. All right, well, we will get started with a few of the questions that we have received so far. The first reads, the calendar year 2024 PFS rule includes information about the attribution methodology for chronic condition episode-based cost measures, including a group-level medication attribution check. What performance years does this attribution requirement apply to? And is there more information about this check?
Yeah, thanks, Olivia. This is Ray. I'm going to send it over to Allie to clarify that.
Thanks, Ryan. This is Allie Newsome with the cost team. So to answer your question, both of the chronic condition episode-based cost measures that were available for MIPS back in performance year 2022, so that's diabetes and asthma COPD, those included a clinician-level medication attribution check for the 2022 performance period. And then starting with the 2023 performance period, the diabetes and asthma COPD episode-based cost measures will use both a clinician-level medication attribution check and a group-level medication attribution check. And this will also apply for the heart failure episode-based cost measure that was added for the 2024 performance period. So for asthma, COPD, and diabetes, we added this check as part of the annual maintenance process, and more information about this is available in the QPP resource library in the MIPS episode-based cost measures chronic attribution methodology materials. It's got a one-pager and an FAQ document, and we will share the link to that resource so that you can review it. Thanks.
Great, thank you, Ray and Allie. Moving on, Elizabeth, a quick question that we received for you. It says for 2024, is the PI exemption automatic for small practices?
So yes, we didn't change our policy. Small practices, those are practices with 15 or fewer clinicians, do not have to submit promoting interoperability data. They will be automatically reweighted. Of course, if a practice chooses to submit data, that data will be scored. So no worries. The policy remains the same as it is for 2023.
Great. And then one more question. Does the PI exemption that is automatic for small practices apply to small practices that are in ACOs, or do they have to submit PI despite being a small practice?
Sorry, that's not for me. ACO team, can you answer that?
Okay, we can move on and then come back to this or connect with you, Jennifer, separately. Okay, and then it looks like we do have quite a few phone questions, so we're going to shift over there to answer some of these questions. Jill, we will unmute your line and you can go ahead and ask your question. And Jill, you may need to unmute on your end as well. Oh, it looks like you just put your hand down. Okay, we will move on. Sarah Bryant, we have unmuted your line and you can ask your question.
Can you hear me?
Yes.
Okay. Just a follow-up to what I think I had asked in the chat already. So I know that when we submit the ECQM or CQM data starting in 2025, like we don't have the option to do that kind of online web-based reporting. Is there a way to like address any gaps in the data that gets submitted or any kind of errors in reporting afterwards, or is that not a thing that happens?
Is anyone able to answer that for Sarah? Okay, Sarah, we will connect with you separately so we can help you there.
Okay, thanks.
Of course. Moving on, Chrissy, we have unmuted your line and you may just have to unmute on your end. Chrissy Brown, your line is unmuted if you want to go ahead and ask your question.
Olivia, this is Lisa Marie, just quickly. So I couldn't hear the last question that was being asked. I could hear that. So could you just repeat the last question? I'm sorry, because I may be able to answer that. I wasn't sure, but like I said, I couldn't actually hear the question.
Yes, if you want to go ahead and raise your hand, we can unmute your line so you can ask that question again. Lisa Marie, we'll come back to that question later on.
Okay, sounds good.
Okay. Moving on, Stephanie Schroeder, we have unmuted your line and you can go ahead and ask your question.
Hi, I was wondering if you could speak to the difference between data completeness for ECQMs and CQMs, please.
The data completeness is the same for, well, so the data completeness requirement is the same for all collection types, in which it's 75%. With regard to ECQMs, I just want to note that when data is pooled, so just the innate nature of an ECQM, when the data is pooled, it actually reports 100% of the data. I'm going to refer to one of my other colleagues, Colleen or Jamie, to elaborate on that, but essentially the requirements are the same, but how data is pulled and what's reported for ECQMs, it's more data that actually exceeds the threshold. Colleen or Jamie, do you want to elaborate?
Sure, this is Colleen with the PIMS team. So for data completeness threshold, what we're looking for is that there is a performance submitted for each denominator eligible encounter. So if you had, say, 50 denominator eligible encounters or instances, however the measure is set up, we would be looking for at least 75% of those eligible encounters to have a performance associated with them, which could be performance met, performance not met, or denominator exception, dependent upon what's in the measure specification.
Great. And then just going back, Sarah Bryant, we have unmuted your line if you want to repeat your question.
Okay. Can you guys hear me?
Yes.
Okay. So my question was that I understand that starting 2025, we'll be submitting some kind of electronic measure, either via CQM or ECQM. My question was, is there a way to address any errors in the data, any oversights, any kind of issues sending it? Like, I know we're not going to be doing the web-based submission, but will there be a way to address any errors in the data that are pulled and going over to Medicare?
So this is Lisa Marie. That sounds like it's like a technical question, because I mean, different errors can be different things. Because like, for example, and I'm just using this as an example, but like for web interface, and you're submitting the data, you know, in the system, it will tell you if there is an error. But with an ECQM and a MIPS CQM, like depending on how like the data is like third party, or if you are self-submitting it, I think it would just depend. But I think for us to give you a real specific like guidance for this question, would you be able to submit a help desk ticket? That would be, I think, a good option for you, so that we can fully understand more of and be able to give you a comprehensive response.
Okay.
Thank you.
Great. We are going to shift back to some of the questions in the Q&A box. So as a reminder, if you do have a question that you'd like to submit, please go ahead and do so through the Q&A box as well. One question that we received reads, when will the specification guides for 2024 be posted on QPP per specialty?
This is Lisa Marie, and all of our specifications, which include like the various collection types for the measures, they'll be posted actually very soon, so in the next month.
Great, thank you, Lisa Marie. Vidya, just one question for you, and I know you answered it, but it may be helpful for the broader group. Somebody did ask if there are any changes to the reporting period for IA, improvement activities.
Sure. So for improvement activities, we did not change the minimum, the reporting period, the performance period rather. You still have a minimum of a continuous 90-day performance period during the calendar year, unless otherwise stated in the activity description.
Thank you. The next question says, regarding the 3 quality measures that are being partially removed, what does that mean? We report all 3, so this person is just looking for clarification on how that will affect them.
So depending on how you're reporting, so the partial removed measures are being removed from traditional MIPS. So if you are reporting traditional MIPS, you would need to find new measures to report. But if you're reporting in an MVP, we retain those measures for use in an MVP. So if you're reporting those measures in a part of an MVP, they would still be available to you.
Thank you, Lisa Marie. We did receive a couple of questions on promoting interoperability. Specifically, will small practices still be exempt from reporting promoting interoperability?
Yes, we just answered that. Yes, they are small practices. Those practices that have 15 or less clinicians will be automatically reweighted for the promoting interoperability performance category. And if they choose to submit data, that data will be scored and the reweighting will be canceled.
Thank you, Elizabeth. And can we go to slide 39 quickly? Thank you. We received a question just specifically asking about this slide. It reads, does this mean that the use of CERT for advanced APM participants can be met with any preference of CERT modules as opposed to CMS CERT criteria?
Olivia, I've got to answer that with not quite understanding the question. We don't have CMS criteria specifically. We have this criteria. What we're saying here is that you can either use the 2015 edition, as we've had in place before, or any such ONC Health IT certification criteria is adopted and updated under 45 CFR 170.315, which are the ONC regulations on this topic, and that are determined applicable for APM. So we are granting flexibility, more flexibility here than we've previously had. I just don't quite understand the language they're using about modules and so forth.
Thank you, Richard.
And maybe I can follow up with them if you can give me their names. I think we could have a conversation.
Yep, absolutely. We will pass that along. And for the person who did submit that question, if you have a follow-up question or clarification, please feel free to reach out via the Q&A box. And can we move to slide 44? Thank you. We did just get a clarification question on this slide. Looks like the person is just asking, does that state that each physician needs to report PI on their own outside of the ACO APM reporting?
Good afternoon. This is Erin DiLoretto. The requirement is that the ACO as an APM entity or the ACO participant, ACO provider supplier, ACO professional that are MIPS QP, MIPS eligible clinicians, QPs or partial QPs report PI and be scored at the individual group or virtual group level. So there's multiple pathways that the Shared Savings Program CERT requirement can be met, whether that's the ACO as an APM entity or the participants as individual groups or virtual groups.
Hi, this is Elizabeth.
Elizabeth, I'm not sure if you're speaking, but we can't hear you on our end. Wasn't sure if there's anything you were trying to add. Okay, we will move on. Can we go back to slide 48, the Q&A slide? Thank you. We did receive a question, and Sabrina, I know you had answered it, but it may be helpful for the broader group. For ACOs that choose to use the new Medicare CQM option, how many measures will have to be reported on and where are the measures?
Hey, thanks, Olivia. Yes, so there are 3 Medicare CQM measures under the APP that ACOs can report on beginning in performance year 2024. These measures are identified in Table 29 of the 2024 PFS final rule. So I would suggest looking at Table 29. It's quality ID, measure quality ID 1, 134, and 236.
Thank you, Sabrina. Video question that looks like you wanted to answer. It says the fact sheet says they need to review, but what exactly does review mean? Do I just read it, or do they need to actually complete the high priority practice safer guide?
So I think I answered it online, you're right. They need to complete the assessment, but I will defer to Elizabeth to clarify.
So you need to review the guide, but it doesn't mean that you have to implement everything that the guide recommends that you do. Our intention is that you are working on doing that, but there's not a requirement that you need to implement everything within the performance period.
Thank you both. And I know we have touched on this a little bit, but we are seeing quite a few questions. So just looking for some clarification on if small practices are exempt from PI, even if they're in a shared savings program ACO.
This is Erin DiLoretto. So not to conflate the policies, there's the MIPS promoting interoperability policies related to small practices. And then was the separate policy under the shared savings program for the CERT requirement, which will be finalized or applicable rather for performance years 2025 and subsequent years. Under the shared savings program CERT policy, the requirements at 425 507 do detail certain exclusions and exemptions to the shared savings program policy. Small practice is currently not one of the special statuses, including small practices, is not one of those exclusions and exemptions that was finalized. Although it is noted in the final rule that CMS is evaluating the appropriateness of including small practice and other special status, and may address that in future rulemaking.
Thank you, Erin. One more question related to small practices. It reads, will the automatic PI exemption for small practices not needing to report PI continue for performance year 2024, et cetera?
Well, we established the policy. We did not change the policy for 2024, meaning that, yes, small practices are automatically reweighted. However, we could propose for a future year to change that policy. But if we do that, it will be through notice and comment rulemaking, and the public will get an opportunity to weigh in. We have not yet established all our policies for 2025, but in the absence of us making a proposal, we will still be automatically reweighting small practices.
Great. And we are seeing a couple of questions just about the links in the chat and asking where everyone can get those. So as a reminder, the slide deck from today's presentation will be posted on the QPP webinar library within the next 2 weeks. And all of these links will be included in the slide deck there. So if you're looking for the slides or these resources, those will all be posted within the next 2 weeks. Moving on through our Q&A, we did get someone just looking for clarification, and it may be helpful for the broader group as well. It reads, can an individual physician register for an MVP and also be part of an advanced APM? Is anyone able to provide some clarification there?
If the person can submit a help desk ticket, that would be great. And the reason I'm asking for you to submit a help desk ticket is because with there are different requirements in terms of who can participate in an MVP, and because they may, as you noted, may participate in different ways other than, let's say, just one particular way, such as an advanced APM. But in your ticket include, like, for example, sometimes there are clinicians that may be included in a TIN that's part of like an advanced APM or part of, like, let's say, like an ACO or an APM entity in which there are multiple TINs, but that provider may not actually be part of actually the advanced APM. So in your ticket, just provide as much information relative to the scenario you're asking about so we can provide you a response. Thank you.
Thank you, Lisa Marie. The next question, for 2024, are practices binded to report MVPs if they register?
Hi, Olivia, it's Sophia. Just to answer that question, no, if you can register to report an MVP, whether that be for 2023 or 2024, right now the 2023 registration period is open till November 30th of this month. And you could register successfully and then choose to then, after registration is complete, report traditional MIPS. Nothing would happen to your score. You wouldn't be adversely affected if you registered and did not report a MIPS value pathway.
Thank you, Sophia. A quick clarifying question on MVPs. This person wrote, is it still possible to submit traditional MIPS and to submit MVPs simultaneously for a performance year? So just looking for some clarification there.
Yeah, you could have two submissions, one being your MVP submission. You meet the requirements of MVP reporting, reporting your 4 quality measures and all the other performance category requirements. And then you separately submit data with the intention of it being a traditional MIPS submission. And what would happen is your traditional MIPS submission would be scored separately from your MVP submission. And we would just take the higher of through our scoring hierarchy to account for your final score. We would not take an MVP submission and then trying to make it apply to your traditional MIPS submission. We could not aggregate it that way. So your MVP submission would be considered separate from your traditional MIPS submission. Both would be calculated and scored separately, and we would then take the higher of to count as your final score.
Thank you, Sophia. We did get a question, somebody just looking for clarification on denominator exclusion and if it's included in the 75% data completeness.
Hi, so denominator exclusions are removed from the denominator eligible population as they would not be eligible for the quality action being assessed within the measure. So those folks that fall within that denominator exclusion are not going to be part of that denominator eligible population.
Great. The next question, do the quality measures that are part of MVPs have different benchmarks than what they did when they were part of traditional MIPS?
No, they do not.
Thank you. And can we go back to slide 20? Thank you. This person is just looking for some clarification on if this means that additions, changes, and removals of MIPS quality measures. So that just looking if someone can just go through this slide a little bit at higher level. Lisa Marie, are you just able to go through this slide quickly?
Sure. So for this slide, specifically, so what element of this slide, or they just want me to go in general for this slide? Because for the 2024 performance year, there's 198 measures, quality measures that are available for selection. Sorry, do you know which element to go over?
I think just in general, looking for some clarification on the additions, changes, and removals of the quality measures.
Okay, so for 2023, we had 200 measures, and now for 2024, we have 198 measures. And so on an annual basis, we review all of the measures within our inventory. And we look to see, like, for example, we have the addition of new measures. So when we add measures, because based on a process that we have prior to a final rule where we take measures into consideration. So let's say there's a more robust measure, we may add that new measure in and remove an old measure or remove a current measure in our program. So with the addition of new measures, it's measures that are a priority area, measures that may be more robust than measures that are being removed. There are also measures that may be in an area that we do not have currently, let's say under a specialty, or may look at a specific like disease or an element of a disease that we're trying to improve quality of care in. So the new measures represent new quality measures that are not currently represented within the current inventory. And as you can see here, we have a lot of our new measures which relate to patient-reported outcome measures. So one thing that one of our high priority area for CMS is, patient voice. So we have more of those measures. So just in terms of our inventory, we just have a lot of new measures that will allow you to report on something that's not currently within the program. And then the measures that are removed, as I indicated, they're either because we're replacing it with a more robust measure. We also have instances in which we remove measures that are topped out. But in the final rule, we list out the reasons for why a measure is being removed, and then the reasons for why we're adding new measures. Also, in a resource that's going to be available, there's a comparison table, and there's an appendix in the comparison table that will actually outline just briefly a rationale for why a measure is being added and why it's being removed. So that's the resource you'll want to look at if you want like more information relative to why a measure is being removed or being added.
Thank you, Lisa Marie. That was very helpful. Appreciate you going back over this slide. We can go back to the Q&A slide, slide 48. Thank you. We did get someone asking, how can we determine our entity level APM QP determination for 2024 or partial determination?
Hi, this is Richard. I'm trying to understand what they're asking exactly. The threshold levels for 2024, I can tell them for all entities. Or did they, I don't know if they mean that, and I can tell you what those are, or whether they meant specifically what their participation levels are going to be in 2024. The threshold levels under current statute are expected to go up to qualify as QPs. The threshold levels are going up to 75% of Part B payments participating in advanced APMs and 50% of patients participating in advanced APM. You have to meet those thresholds in order to become QPs in performance year 2024. If they're talking about looking up what their entity's performance levels actually are, that's we have the tool at the QPP website to go look up what their participation levels are during 2024.
Thank you, Richard. Yes, that is helpful. Elizabeth, one quick clarifying question for you. The 180-day PI period, is it also for small practices?
Yes, it's for all clinicians.
Thank you. Moving on, for MVP measures, do vendors need to support all of the measures within the MVP?
Ideally, they would, but we did finalize policy within this rule to clarify that third-party intermediary, particularly we have, QCDRs and registries that are very specialty specific. And when we have MVPs that may reflect multiple specialties, it may not make sense for them to support all the measures in the MVP, because if, for example, they are a QCDR that only supports the surgery specialty, then it may not make sense for them to support measures that reflect physical therapy or occupational therapy or even anesthesia in that sense. So with that in mind, we made we finalized policy changes to allow the QCDR to use their discernment to, support as many measures as they can that are clinically relevant to the population that they support. And then, the same would apply to the registries as well. So, to the extent a given third-party intermediary can support as many measures, that gives clinicians more choice to then select which measures that are, that resonate the most with their practice and report that. And ideally, vendors wouldn't limit that choice for the clinician. So, but obviously in the case of specialties not necessarily support, QCDR is not supporting all specialties, then it would make sense for them to limit what measures they support.
Thank you, Sophia. It looks like we have a couple of additional MVP questions. So starting with the first, what is the payment adjustments for reporting MVPs in 2024? Is it the same as traditional MIPS?
Yep, it's the same.
Thank you. A clarifying question, it says for MVPs, is this statement still true for 2024? If an MVP includes measures that are only reportable through a QCDR, qualified registries, and health IT vendors, we'll need to support all other quality measures and MIPS clinical quality measures within the MVP.
Well, I think, as I mentioned before, the caveat being if the TPI, the third-party intermediary, is of a single specialty, we finalize modification to that policy. So again, continuous as previous years, only QCDRs can support QCDR measures. We are not mandating that QCDRs must support measures that they don't own within the MVP. That's their discretion. They have to still seek permissions as they have in the past. But the only clarification we're providing here is you as a third-party intermediary have some discretion as to which measures within the MVP you support, particularly in instances where an MVP includes multiple specialties. It may include various clinician types and specialties. So we want to just be cognizant that not all third-party intermediaries support all specialties or clinician types, and that would give them some flexibility to use their discernment to pick which measures within the MVP they support. Ideally, they are transparent with that with their clinicians and clients they support.
Thank you. And Sophia, just a quick clarifying question. Somebody asked, when did you say that we can submit both MIPS and MVP for 2023? And will the highest score be what is taken?
Yep, the scoring hierarchy was finalized last year for 2023, so it's available from 2023 onwards.
Great, thank you. I know we are almost coming up on time, so just gonna take one or two more phone questions. Sydney Sit, we have unmuted your line and you just need to unmute your line to ask your question.
Okay, can you hear me? Hello,
Yes.
can you hear me? Okay, my question is on the SAVER guide. We are a ACO in the MSSP with about 200 practices. My question is that is that each of the practices need to attest the SAVER guide, on the individual level, or the ACO can actually attest on behalf of all the practices that go. So thank you.
That's an ACO question.
Hi, this is Erin DiLoretto. Would you mind submitting that question to the Shared Savings Program Help Desk so that we can do a little bit of research and get that back to you?
Okay, thank you. Yes.
Thank you very much.
Yeah, thank you.
Great. Vet Sylvie, we have unmuted your line. So you just need to unmute your mic and then you can ask your question.
Hi, I have a practice who only used decertified or uncertified product the first 2 months of the year, but they are able to meet population requirements in the second vendor now that they've transitioned to a different EHR. Can they solely report the second EHR data and meet completion requirements through a registry and just ignore the first 2 months of the information since it wasn't in a certified EHR?
I'm assuming you're talking about the submission of electronic clinical quality measures. Is that correct?
Yes.
The quality team, this is for you.
Okay, I know we're coming up on time, so Yvette, if you want to just go ahead and submit your question through the Q&A box, we can get back to you there.
Okay. I did that. Thank you.
Yes, we will connect you with the right person to get your question answered. Okay, I think we have time for 1 or 2 more questions. The next question just says, looking for clarification, saying there are no exceptions for clinicians who do not have CERT. Can you expand on this? Does this mean that the PI hardship exception is going away for 2024?
There are PI hardship exceptions. There's just not a hardship exception for those who lack certified EHR technology. And that's, I would be curious to know if they were applying what criteria they were selecting. The criteria we offer hardship exceptions for the promoting interoperability performance category is if you had decertified EHR technology. I will tell you, ONC has never decertified a product. So that's not really applicable unless they do actually decertify your cert. Second category is you have insufficient internet connectivity. The third is extreme and uncontrollable circumstances, and that would be a disaster, a practice closure, or a severe financial distress or vendor issues, and that does not include lack of cert. And the fourth one is you lack control over the availability of certified EHR technology. So those are the only reasons you can apply for a hardship exception. And these haven't changed for a while.
Thank you, Elizabeth. Appreciate that clarification there. All right, well, thank you everyone for submitting questions. I know we're just about at time here, so I will turn it back over to Julie Johnson.
Yes, thank you. This concludes our presentation. If you have a question about the 2024 Medicare Physician Fee Schedule Final Rule that we didn't answer, or if you have feedback about what we presented here, we encourage you to reach out to the QPP Service Center at qpp@cms.hhs.gov. Please know you can always find more information, as well as the resources mentioned in this presentation, on the resource page at qpp.cms.gov. Thank you for taking the time to participate in this webinar. We appreciate your interest and we look forward to continue to work together.